Hi, good evening, everyone, and welcome to Dr. KK's Med Talks, which is a non stop show which is about conversations that matter. And this is an educational initiative supported by Eli Lilly. Now, I'm your host today, Dr. Om Lakhani, and for today's talk, we are going to pay attention to body's most powerful yet misunderstood regulator, and that is the body's eating behavior. The hormones behind the eating behavior, why do we gain weight, and what really would help us to lose that weight. Now, for many years, appetite was seen as a simple matter of willpower or habit. But modern science reveals a far more intricate story. Our urge to eat, stop eating, and feeling satisfied, which is known as satiety, is often guided by a beautifully coordinated hormonal system that works around the clock. In this session, which is going to be very interesting, we unpack how these hormones work, why sometimes they fall out of balance, and how this affects the weight, cravings, metabolism, and our overall long term health. So, that is what we are going to discuss today. It's going to be a very exciting session. We have an exciting guest today for this. So, looking forward to having you all for this session. So let's begin the today's sessions with some updates from the field of obesity. So here are some key updates from obesity. Now, there was a recent study that looked at some commonly used cooking oils and fats like soya bean and palm oil, butter and margarine, and they found that when consumed often in large amounts, it increases body's weight, fat accumulation, and leads to metabolic problem. I think not surprising at all, right? So I think you have to be very careful about the fat because that could contribute to, well, your fat. And there's a very interesting new analysis that has identified that the hormone estrogen is a major driver of aggressive breast cancer in postmenopausal women with obesity. So again, this is something which is a key finding, and in future you could have medications which could help in this condition. A very interesting study and very important for parents out there. Kids who have smartphones by the age of 12 have higher risk of depression and obesity, according to a new study. So you have to be very careful as a parent if you are considering giving your child a smartphone. Again, a new study which has highlighted, and I think it's a very interesting study, really enlightening in a sense. A new study has highlighted that marriage and close social interactions and connections can increase the risk of someone becoming overweight or obese, as partners often mirror each other's eating habits and activity patterns, and that often influences long term weight. Well, I think a lot of my patients often come and tell me that I am obese because of my wife and vice versa. And I think that is probably true according to a recent study. So, a very interesting and thought provoking study. And very interestingly, again, WHO has released its first ever guidelines supporting the broader use of modern weight loss medications, officially recognizing obesity as a chronic disease. And I think this is game changing. And that's why we are here today to really discuss about obesity and how we can make an impact to our day-to-day lives of ourselves as well as of our patients. And in this particular aspect, we are going to take more details with our special expert guest today. So, can we have today's topic? So, after that, updates from obesity. Today, we are going to dive deep into the hormone and what hormones really lie behind hunger and satiety. So, we'll specifically point out what really leads to hunger, what really leads to satiety, and how does the hormonal system, the endocrine system, really play into the entire picture. So, for today's topic, we are going to have with us a very special guest, someone who is widely recognized in the field of endocrinology, someone who is highly respected in this field, and most importantly, a brilliant mentor and a brilliant person and a brilliant storyteller. So, we have with us Dr. Abdul Hamid Zargar, sir, as we understood from backstage, would like to be called as Dr. Hamid, right? And Hamid is his real first name. The rest of the things, as he said, is well generic in his words. So today we are going to have Dr. Hamid sir as he's a distinguished endocrinologist. Actually, he needs no introduction, but just to do the needful. He's a distinguished endocrinologist and the director of Center of Diabetes and Endocrine Care. He's renowned for his expertise in the field of diabetes, thyroid disorder, metabolic health, and endocrine research. And he's one of those who's who of endocrine field in India, right? He's a mentor to many hundreds of endocrinologists who have been trained, trained by him. He has played a pivotal role in advancing evidence-based endocrine care in India. Like I said, is a cornerstone and he's a figurehead of endocrinology in India. He has decades of clinical leadership, decades of research leadership, and is widely respected for his patient-centered approach. Patients love him, and a lot of who's who of India have been his patients as well. So, you know, as you know, he has an academic contribution. He has several commitments in improving the chronic health of chronic diseases like obesity, as we'll discuss today. So, welcome, sir, and welcome on the stage. And it's an absolute pleasure to have you today.
Thank you so much, Om. It's a real pleasure connecting with a very elegant youngster. And probably, today we have an amazing topic to discuss. And particularly, if you look at it, this whole phenomena I have seen unfolding in front of me in the last four and a half decades.
Right.
From a relatively starved nation to a reasonably thickened and obese nation, and how to go about it. Many aspects
Absolutely.
of these, even as a postdoctoral student, we never even imagined and talked about. But today, this is the epicenter of all non-communicable diseases that are engulfing the whole country and the whole globe. Probably, there are areas which are even worse than us. Yes, it's a pleasure looking at whatever hormones do to our body and whatever needs to be discussed and whatever has evolved in these last 30, 40 years, because everything that we are going to discuss today is relatively new. It's not like typhoid or cholera
True.
or tuberculosis. So
True.
all these things is new. Thanks being here and pleasure connecting with you.
Absolutely, sir. Thank you so much. And you very rightly said. So, as human beings, and especially as Indian doctors, we have conquered a lot of challenges which our country has faced. For example, we had challenges of malnutrition, as you very rightly said. We were a country where we used to say दो रोटी भी नसीब नहीं होती थी. एक जमाना था. Now you have well we are in a you have a problem of plenty basically, right? We have so much food that not much we can eat, and then we had the challenges of infectious diseases, which also we overcame, right? We had a lot of vaccination programs and a lot of tuberculosis related programs across the country across the years. And I think now we are in the third frontier of the medical challenge as we are facing as a young nation, and that's the challenge of obesity and chronic metabolic diseases, as they are widely called by the government as an NCD, non-communicable disease spectrum. And I think we are in that era where these are the major challenges that we are facing, right? As has been seen in many countries, that as the affluence of the country increases, the middle class is the one which is most affected by chronic metabolic diseases, and that's where we stand. So, Hamid sir is a perfect person to guide us through this thing. And sir, आज हम ना एक will focus on one aspect, that is appetite, and that is as commonly known as bhook, right? And that's the we'll see how we balance जैसे ये भूख और satisfaction के बारे में satiety, that is what we'll discuss. And let's start with this very question, sir. As endocrinologists, we are always fascinated by what hormones really drives our system, and what drives us to do certain things. So, which hormone, sir? Which is that hormone that regulates hunger, that regulates bhook, which is so vital for both our survival as well as a bane of our existence?
Before I would dwell on that, I
Yes.
must tell you, if you look at gut, it is it is the biggest endocrine organ in the body that produces so many
Yes.
hormones. And
Absolutely.
many times, as endocrinologists or as public, we associate production of a particular hormone to a particular organ.
Correct.
I'm so like, ACTH, it has to come from a corticotroph in the pituitary. वहां से ही
Correct.
आना है.
Correct. बिल्कुल.
और T3 T4 थायराइड सेल से ही आना है, TSH के असर से.
Correct.
And that holds true for majority of things that we keep on discussing in conventional medicine and endocrinology vis-a-vis endocrinology.
Yes.
But there are certain areas where, there is no monopoly of a cell on a hormone. There are
Right.
many hormones that are produced in different parts of, let's say, gut.
Hmm.
I'll give an example. Like all of us know about, let's say, GLP-1 that we commonly talk about, right?
Right.
And
Right.
the insular axis that we will talk about. The similar small concentration of hormone is also found in our own hypothalamus. So, in
Yes.
a similar fashion, when you talk about growth hormone inhibiting hormones, but the same hormone is found in a small delta cell in the pancreas.
Correct.
And in a similar fashion, if you look at it, I would say three. Firstly, hormone is an important part of controlling appetite and satiety, as you very aptly said. But there are many other neuropsychiatric phenomena that either independently work or might work through influencing these hormones,
Yes.
right?
Yes.
And two important hormones that we keep on talking about. One, the hunger hormone, that is ghrelin, and we have been talking about it for just last decade,
Yes.
not half a century, less than that. And and then second is satiety hormone, that is leptin. And this we
Yes.
have been talking about for a couple of decades now, two and a half
Yes. Yes.
decades.
Yes.
But I would personally believe that GIP-1 and GLP-1 also come into this gambit in different forms, because, like, as I was just now telling you, we talk about ghrelin, and we fundamentally know that it comes from the upper part of the gut, stomach, and whatever the stimulants or suppressants there are.
Right.
But there's a small amount of this found elsewhere in the body.
Right.
And that whatever it impacts and wherever it impacts, but also has a wider impact on different parts of the body. And probably, if I enumerate in order of priority, ghrelin, leptin, and probably GLP-1, and last probably GIP-1. That in order
Yeah.
of that importance, the way we understand them today, probably even a few years back, GIP-1 also we would not have probably included,
Not at all.
but
Yes.
we are tempted to do so. Today we are.
Right.
I'll be more cautious today, in view of whatever
Right.
data is recently emerging. So yes,
Right.
these are the hormones that are there. They play. We have a
Absolutely.
satiety center, we have an appetite center, and there are many things that influence it: neural, psychogenic, and hormonal. And today we are looking at the
Yes.
hormonal component of it. So probably we'll be talking about these two, three hormones today in depth to understand the basic endocrine biology
Yes.
of
Yes.
satiety and appetite. Um,
Absolutely. Yes, absolutely. So just to summarize, sir, what you said, two very interesting, and I pick on these points, and I think it's very vital for the audience also to know that, like you said, the gut, the GI tract, is the largest resource of hormones in the human body, and it's the one which endocrinologists have been ignoring for a long, long time, right? Even though that was the one of the first areas where hormones were actually discovered, and the physiology, entire the branch of physiology actually came from the gut, and I think a lot of the understanding has now. Over the years, we focused more on the thyroids and the pituitaries and the adrenals, but we forgot that there's a big bank of hormones, that is the gut, the GI tract, which influences a lot of things that we do. And very interestingly, and I think that's a great point you raised, sir, that a lot of the times you have one organ having a monopoly on a particular hormone production, but the gut hormones, where there is no monopoly, right? Those hormones are produced by different, including different parts of the body, as well as they act on different parts of the body, and I think that makes it a very interesting thing. So three hormones, four hormones that you talked about, right? You talked about ghrelin, you talked about GLP-1, you talked about leptin, and you talked about GIP, right? So these are the four hormones we talked about, and let's unpack those. So let's start with the ones which are in the most discussion these days, because of the medications that are available. Let's talk about GLP-1 and let's talk about GIP. And let's first talk about GLP-1, sir. And why? What is exactly GLP-1? Why is it there? And how does it act? And how do we exploit that from a pharmacological perspective?
It was, an amazing incidental finding.
Yes.
Michael Nock, I was sharing one day a session by Michael Nock,
Yes.
and he's the person who published a paper in Diabetology in 1987. Very surprisingly, normally अगर हम ऐसे देखेंगे routinely as endocrinologist, you might go back to 80s, go
Right.
back, so quite long back for you, and theoretically ऐसा लगता था कि suppose now you give a glucose load or caloric challenge, किसी को मुंह से देंगे या किसी को आईवी देंगे, लगता था जब
Right.
आईवी देंगे तो एकदम शुगर बढ़ेगा तो इंसुलिन should be shoot up. I'm
Right.
talking about a normal human being,
Yes.
right?
Yes.
And
Yes.
what Michael Nock found out, when you give a caloric load through IV and you plot the secretion of insulin, right? And you see area under the curve. और कितना insulin, you postulate कि इतना insulin बन रहा है. And then you give the same caloric load through gut. Now, normally by conventional primitive thinking, कि gut से थोड़ा कम होना चाहिए था, उससे IV से ज़्यादा होना चाहिए था. What he found out, when you give the same caloric load through gut, insulin secretion is more than when you go through IV route. This is the first time he thought that there is something in the gut which is modulating and potentiating and amplifying the production of insulin from beta cells. And it was sort of a surprise thing. And the first thing obviously comes to the mind that whatever is in calories are going to the gut, it is stimulating something before not only getting absorbed into the circulation, but also stimulating simultaneously something that is preparing the beta cells for insulin secretion.
Right.
And half a decade later, he found out this is GLP-1. And GLP-1 में क्या उसने देखा, which will be now relevant for the newer drugs. Okay, not only does it increase the insulin, and so insulin बढ़ जाता है, but it also suppresses glucagon.
Yes.
And when he replicated the same experiment with patients with conventional type 2 diabetes mellitus of late 80s, he found out that this amplifying impact of gut on insulin secretion was blunted. You get my point? Now, whatever
Absolutely, sir.
potentiation of insulin was happening because of this intra-gut caloric load, in type 2 diabetics, it is not happening. The amplitude of the insulin is not same. So what does it
Correct.
mean? That जो भी वो फैक्टर गट में है, बहुत सारे टाइप 2 डायबिटिक्स में ये कम है.
Correct.
Right?
Correct.
So that was one of the first. And then he went on to find out what is in the gut. Or in 1992, he published a paper again in Diabetology, isolating this polypeptide and showing when you give it in vitro, and it increases insulin. And not insulin क्या उसने endogenously C peptide के endogenous insulin actually बढ़ रहा है, pancreas से आ रहा है ये.
Right.
And then he found that suppresses the glucagon.
Glucagon also. Correct. Bilkul.
So we had a new era that controls the calorie consumption and metabolism of the calories.
Absolutely.
And this happened for the last just 3 decades. And then,
Yes,
please.
Sir. No. So please go ahead.
So much later came the comprehension about ghrelin. And see, in the Western world, coronary artery disease and obesity started catching the eye of the healthcare operators in 60s.
Right.
जैसे यूएस में वो पोस्ट वार में वो वर्ल्ड वॉर 2 के बाद 10-20 साल वो अभी भी वो बॉर्डर लाइन में थे, बट देन दे स्टार्ट रियलाइजिंग पीपल आर थिकनिंग एंड
Becoming
देन
obese
दे
and
स्टार्टेड लुकिंग एट ओबेसिटी. वहां तक उतना वो था
right,
नहीं मामला,
right, right, right.
एंड देन we in our country we started becoming aware of. अभी आप बता रहे थे ना कि इतने सालों से हम डायबिटीज एंडोक्रिनोलॉजी के पहले 10 साल कभी डायबिटीज हमने बात ही नहीं की.
Correct, correct,
पहले 10 साल वही था, शियान सिंड्रोम कितना है, हाइपोथायरायडिज्म
correct.
कितना है,
Iodine
आयोडीन
deficiency कितना है?
डेफिशिएंसी कहाँ कहाँ पे है,
Correct, correct.
हाइपोगोनाइडिज्म कितनों को है, टर्नर
Right,
सिंड्रोम.
right.
फॉर अ डेकेड आई एम टेलिंग यू, आफ्टर बीइंग
Yes,
अ endocrinologist.
right,
It was
right,
in early 90s, after a decade I had been an endocrinologist, that I still remember एक पेपर आ गया डायबिटीज केयर में. मैं फर्स्ट रामचंद्र ने एक एपिडेमियोलॉजी का पेपर अपने मुल्क से छापा था बीएमजी में 1987 में. मैंने
right, sir.
पढ़ा था, बट नो वो वन ऑफ द डिजीजेस, क्योंकि उस टाइम पे आयोडीन डेफिशिएंसी वाज अ नेशनल कैलामिटी.
That was a problem. Yes,
Everybody
that was.
involved. It was a huge issue. Something like that iron
Mm,
deficiency we used to talk about. Now, the way we talk about
yes.
vitamin D deficiency these days. First
Mm,
time the WHO talked about uh, how diabetes has been a couple of decades early and how is now. And that started postulating that in 5 years
mm,
what will happen, 10 years what will happen, 20 years what will happen. And it directly corresponded with the onset of obesity.
yes.
So first time we started looking at obesity in late 90s, and we found out that yes, it's a genuine issue now. And
Right.
जहाँ तक वो obesity बढ़ती गई, and whatever postulations, let's say for our own country, forget about the rest of the world,
Mm,
हर बार
mm,
हम सोच रहे थे कि डायबिटीज इतना होगा, मगर उस दिन उससे दुगना ज्यादा होता था.
mm.
क्लासिकल एग्जांपल मैं दूंगा ओम. जब मैं एमडी किया हिंदुस्तान में, हम पॉस्टुलेट किए थे 1 करोड़ डायबिटीज है. जब मैं
Right.
प्रोफेसर बना ना 1997 में, एक आरएसडी था चंडीगढ़ में,
Mm,
एंड आई वाज आस्क्ड टू लुक एट द पॉसिबल इकोनॉमिक रेमिफिकेशंस ऑफ डायबिटीज. आपको पता
right.
है कितना उस दिन डायबिटीज था? 1.9 1.67 करोड़.
Right.
जब मैं व्हेन आई
So,
लेफ्ट इंस्टीट्यूट इन 2011 तो ये 6 करोड़ का था.
mm,
कोविड से पहले 7 करोड़ का था. कोविड के बाद
right.
का 10 करोड़ का है. हमारा
Right.
मानना है, और वी विल नॉट गेट इनटू दैट कि 20 करोड़ का है. पॉइंट इज,
Right.
this whole take off point was because of obesity, and that is
Yes.
how people started getting interested into the
Mm,
endocrinology of obesity. क्योंकि लोगों
right.
को लगा
Right.
कि हम कहते हैं कि 1 करोड़ से 2 करोड़ हो जाएगा, ये 2 के बदले 3 होता है. हम तो कहते हैं
Mm,
2 से अब 4.5 होगा, ये तो 5.5 होता है. Then we realized,
mm,
and that's why these people started looking at the endocrine hormones, not with us alone, not
mm,
with us alone, globally,
mm. Correct. Correct.
globally. So that's how people started looking at what controls appetite. And उसी
Mm,
में ये ghrelin discover हो गया fundamentally from gastric mucosa. And
mm.
then it was isolated even from hypothalamus in different parts of
Right.
the body. But basic isn't that जब stomach खाली हो जाता है, and then this is a stimulus for ghrelin to come in. आप कुछ खाओ.
Right.
And this
पेट
stimulates
में चूहे दौड़ रहे हैं. So basically, you have
पेट में
stomach
चूहे
hunger.
दौड़ रहे हैं, and you
Yes.
fill the
Yes.
stomach with something. Say नहीं, अब
Yes.
हो गया, कुछ हो गया,
Correct.
हल्का हो
Correct.
जाओ, अब
Correct.
थोड़ा settle down.
Yes.
वो जो
Yes.
सर्ज हो रही थी
Yeah.
वो कम हो रहा था.
Right.
So in a
Right.
similar fashion, quite some time later.
Right. Very interesting. So again, I think beautiful point you said that the era of endocrinologists also has changed. We started with the era of iodine deficiency, then moved to the era of diabetes, and now the next generation is about obesity, right? So I think that is where also the entire spectrum is also changing. Very interestingly, so GLP-1, Michael Nock, a famous researcher, 92, 93, he published that famous paper. I think at some point maybe he should also be considered for Nobel Prize. I think because he's now his work is the one which is now helping save lives of millions of people, not just with
Oh,
obesity and
absolutely.
diabetes. but with cardiovascular disease also. So I think that's a game changer completely, and is dedicated work. He comes to India also quite often, and I think it's a great honor that we're discussing him today. So just to again reiterate the action of GLP-1. And GLP-1, like sir said, original idea was that you had this incretin hormones where there's a difference between if you give glucose IV versus glucose orally in terms of the insulin response, and that is where the incretin pathway was discovered. But I think one more thing which was overall found out, that GLP-1 is like an ileal brake. So it's released by the cells of the ileum, and it's a signal to say that अभी बहुत खाना आ गया इंटेस्टाइन में, राइट, ये जो नैरो पार्ट है बहुत खाना आ गया है, तो वो आगे जाके वो पीछे जाके सिग्नल देता है टू द स्टमक दैट ये अभी बहुत खाना है, अभी इसको स्लो डाउन कर दो, राइट, स्लो इट डाउन. सो यू हैव दैट slowing of the gastric emptying, leading to a satiety feeling. And sir also talked about ghrelin, sir, and we have friends in bariatric surgery who used to talk a lot about ghrelin back in the day when they used to do sleeve gastrectomy very commonly, and they used to say that ghrelin jo hormone hai, right, gives a sense of fullness in the stomach. Ghrelin, in fact, it's the opposite. So your ghrelin, which says that this stomach is empty, whereas when you are full, it kind of slows down in terms of the release. So I think that's a very interesting thing. Two more hormones, sir. So leptin and GIP. So let's first talk about GIP, sir, because GIP thoda it's a new kid on the block, where you rightly said, and that is something which not many people know about. So a little bit about GIP, sir. What do you understand about GIP, and how does it really?
GIP also now it got it. Many you won't know when it initially was discovered. People thought it was an inert hormone. It didn't have much of a biological activity.
Correct.
But now we know it probably still, it also has an insulin stimulatory activity, but it does not seem to suppress glucagon.
Yes.
And if you look
it has
at
a dual action glucagon. Yeah.
dual action.
So
and
dual action. So at a lower sugar it stimulates, higher sugar it suppresses.
Absolutely.
So yeah.
If I'll come back to ghrelin and leptin. But if you look at it, I'll truncate this a bit.
Right.
जैसे मैं अभी रॉजर अंगर का वो ग्लूकोगॉन वाला मामला कह रहा था, I would still say if you look at GLP, GIP and glucagon, अभी हम उसके ट्रिपल एगोनिस्ट की तरफ देख रहे हैं ना, जो अभी हम आगे जाके इंशाल्लाह डिस्कस करेंगे, hopefully. So ये important है कि probably many of those things still are yet ill understood. See, you look at a clinical efficacy of a molecule, but its biology would take a while to completely understand it. So, अभी भी लोग हैरान है कि अब आप ग्लूकोगॉन एगोनिस्ट देते हो फिर भी वेट कम होता है. So it means उसके जो भी we are this time, at least in our practice in our own country, more concerned, ग्लूकोसेंट्रिक के कई डायबिटीज ऐसे तैसे हीमोग्लोबिन A1C थोड़ा कंट्रोल में हो जाए तो कोई 7 7.5 तक रहे पॉपुलेशन में. But I think with this obesity thing, if we really want to put brakes on this, it's not just an epidemic, is it? It's जैसे वो velocity किसी चीज की होती है ना, ये acceleration है.
Right.
Metabolic diseases का वहां से
explosion, logarithmic, like a atom bomb, right? So you have this chain reaction.
Now we understand in a big chunk of people the cause is this obesity. So academia, industry, the clinician is now focusing more on it, and focus would be on all these three hormones in years to come.
Absolutely. So again, just to kind of reiterate and summarize. So you have GLP, which we already discussed, right? It's an ileal brake, and like sir said, it's a factor which kind of influences oral versus IV glucose in terms of insulin release. Additionally, ghrelin, which we already talked about, it's the one which produces hunger, and when suppressed leads to satiety. GIP, interestingly, sir said, for a long time we didn't know, but now we know that GIP receptors are present on adipocytes, and there is some, thinking that it actually reduces the intra-adipocyte fat content, which is one of also the important mechanism of action. And leptin, very interestingly, is like a meter which tells that body ka fat kitna hai, what is the total store of body's fat, sir. Can you tell us more about leptin, sir? And sir is a great teacher in endocrinology. I still remember many years back, sir. आपको शायद याद नहीं होगा. फर्स्ट टाइम आई मेट यू वाज एक बैंगलोर में एक यंग एंडोक्राइनोलॉजिस्ट के लिए कॉन्फ्रेंस था, एंड दैट इज द फर्स्ट टाइम आई लिसन टू यू, एंड आई वाज सिटिंग राइट इन फ्रंट रो, राइट, एक छोटा हॉल था, फ्रंट रो था उसमें, आई स्टिल रिमेंबर, एंड आई लुक्ड एट यू with you know those dog eyes, uh, grasped so many concepts that you told me, and I think it's a privilege today as well to learn that a little bit about leptin, sir. Thoda throw light on that.
Prasanna Kumar and me used to yearly conduct, which we used to call it
Yes,
endocrine Gurukul.
correct. So I attended that one, sir. I still remember the first
So
time I met you
we
there,
should
sir.
get
So
young endocrinologists and
yes,
tell them
yes,
our ways of looking at it, and
yes,
listen
yes.
from them their ways of looking at it. And we
Right,
did it
right.
for quite few years with
Yes,
endocrinologists.
yes,
Prasanna
yes.
Kumar, an amazing human being, an amazing clinician.
Absolutely, sir.
Leptin is a hormone that comes from adipocytes. But
Hmm.
again, like ghrelin, adipocytes do not have the monopoly on this.
Right.
And this is when ghrelin was something that was giving us hunger pains. चूहे
Hmm.
दौड़ रहे हैं. This is supposed to
Hmm.
give satiety. But this
Right,
also,
right.
as ghrelin I was telling you, is also available in the hypothalamus
Hmm.
and elsewhere also in the body. So
Hmm.
whatever the interplay of hormones at the hypothalamic satiety and appetite center is a fine
Hmm.
modulation of these two. And you'll be amazed to
Hmm.
know that GLP-1 also originates in the same, also can be found in this. But you know what is the difference on? There are many hormones which are known today and which are likely to get known, which
Right.
are in such minuscule quantity present in a particular cell line that, like somatostatin from
Hmm.
hypothalamus pituitary area would not reach the gut because it's a very short
Correct.
half-life and small. It will directly influence the somatotroph,
Right.
right?
Locally.
It's a paracrine
Right.
effect. So when I
Hmm.
talk about a GLP-1 in the hypothalamic area, it may not necessarily be the GLP-1 of your ileal region,
Right. Right.
but it's a small amount that is coming there only because a short half-life, how long it gets exposed to the
Hmm.
satiety or hunger center. So in a similar fashion, leptin activates satiety center. अब बहुत हो गया. No, theoretically imagine somebody has eaten,
Hmm.
somebody has got,
Hmm.
no, it's gone to the circulation, something
Hmm.
has got into the fat cells. अब कि यार आप बस कर ले यार, अब
बहुत हो गया.
इस वक्त के लिए
Correct.
आप बस कर ले.
Correct.
And when that
Correct.
a period of starvation sets in,
Hmm.
so,
Hmm.
then third, imagine now you have a prolonged fasting. Now
Hmm.
you first go with glycogenolysis, then you go
Hmm.
with gluconeogenesis, then you go
Hmm.
with lipolysis. अब जो lipolysis
Correct.
होता है तो लेप्टिन भी कहता है यार अब उसकी
थोड़ा खा ले.
क्वांटिटी भी होती है
थोड़ा.
कि नहीं,
Correct.
कम होते भाई खाना मिले तो ठीक ही रहेगा. अब सटैटी
बराबर.
वाला मुझ तक बात
Yes.
आ गई, अब सटैटी वाला मामला नहीं है.
बराबर. बराबर. True,
Yeah.
sir.
So,
True.
so they've in a very fine-tuned fashion,
Yes.
orchestra this, and
Right.
I'm sure that this whole thing also gets simultaneously influenced by neuropsychiatric factors.
Yes. Yes.
Uh, I remember, young endocrine days. You remember, pseudo Cushing's होता था ना, हम कहते थे कि भाई,
Hmm.
if you 1 milligram DEXA separation test, so
Hmm.
कई लोगों को जिनका डिप्रेशन है
Right.
उनको ये फॉल्स आएगा, सप्रेस नहीं होगा. 2 मिलीग्राम कर
Positive
लोगे
आएगा.
नॉर्मल होगा.
Correct. Correct.
So it means, and in a similar fashion, it has a impact on that hypothalamus to modulate eating. But
Hmm.
Kudrat ne bahut, isn't it
Right.
is stunning how nature
It
has
is
done.
beautiful.
Isn't it? It's only that
Beautiful.
we don't
Beautiful,
understand.
sir.
Imagine
Very true, sir.
picomolecules,
Yes.
femtomolecules, making
Hmm.
us what you and me are, making us what
Right.
you are, and
Right.
that having an endocrine basis. And
Very true, sir.
the moment is understood, something can be done about it.
Yes.
Firstly, we need to understand it. So yes,
Hmm.
I'm sure that most things will happen now around these hormones in years to come.
Yes. Yes. Very
It
true,
is
sir.
bound to happen because
Want to happen because now we have opened that door, sir. Up that door for treatment in that regard has opened up. So very
absolutely.
interestingly, So I think, and again, let me dissect this point also. Very interesting thing you said, sir. तो एक तो हमने देखा कि your gut hormones and the hormones related with the adipocytes, the GLP-1, the GIP, the leptin and ghrelin. But beyond that, जो हमारे conventional hormones हैं, उनका भी impact होता है satiety and diet पे. Like सर ने आपने very rightly said about stress hormone cortisol, right? हम सब जानते हैं कि जिनको Cushing syndrome है या जो steroids लेते हैं, their hunger increases, we also know about this term stress eating. We have chronic high levels of cortisol and you'll eat, basically your hunger increases. Same yeah, we know about thyroid, sir, that again, thyrotoxicosis will lead to reduction of weight. Hypothyroidism will lead to weight gain. You also know about insulin, that being anabolic in nature would also lead to progressive weight gain. So there's a beautiful interplay of all these hormones. So let's then talk a bit about, हमने gut की बात की. Let's talk a little bit about the brain, sir, because I think you touched upon this point and you said that you were alluding the point that you have beautiful interplay in the GI tract and the adipocytes, but you also have a beautiful interplay in the central nervous system. So how does the brain influence the satiety and hunger? How does that really take place, and especially the hypothalamus?
If you look at, we normally, whenever we talk in endocrinology, we talk about a master gland, right?
Yes.
Pituitary.
Yes.
जो मैंने पहले बात किए थे ना, वो कन्वेंशनल हमारे सेल टू सेल हार्मोन की. ये तो LH यहाँ से बनेगा, FSH यहाँ से बनेगा, मगर गोनेडोट्रोपिन एक यहाँ से आ जाएगा,
राइट.
अब जो सेंट्रल नर्वस सिस्टम अगर आप देखोगे, अब हम अभी पिछले 20 मिनट से हाइपोथैलेमस के इर्द गिर्द बात कर रहे हैं, राइट. और इसका और पिट्यूटरी का अपना एक सेपरेट पोर्टल सिस्टम है सर्कुलेशन का, तो एंडोक्राइन सिस्टम वहीं से जाएगा, पर इससे एक नर्वस कनेक्टिविटी भी है. अब इमेजिन थ्योरेटिकली, अब ऊपर ब्रेन, एंड वी नो हाइपोथैलेमस इज अ पार्ट ऑफ द ब्रेन,
करेक्ट,
राइट, and we talk about so many hormones. It's a connecting bridge, central nervous system and endocrine system there. And whatever, अभी आप citrus eating करते हैं ना, तो central nervous system से ही शुरू होता है ना, and then it ends up in influencing your hypothalamus.
Correct.
And this nature also, today, if you look at it from a physician's point of view, from a psychiatrist's point of view, from an endocrinologist's point of view, even there we are still not having such an in-depth understanding जितना होना चाहिए अभी. We are still looking at newer hormones, newer connections, newer neural connections, the connect between somatic brain, the parasympathetic and sympathetic supply, and then its connectivity to the hypothalamo-pituitary axis, and then to the rest of the body. बहुत सारे चीजें हम समझ गए हैं. मैंने बताया ना, इमेजिन के जब मैंने डीएम किया ना, there was nothing like ultrasound.
Right.
Can you beat it?
Okay.
Or
so I was not born then. That so
I remember. So, one day Dr. Dash asked me, "See, a bureaucrat, वो कलकत्ता से आया था, तो इसका कुछ हाइपोगोनाइड का प्रॉब्लम है." मैंने उसको अपने कमरे में एग्जामिन किया, अनडिसेंडेड टेस्टिस. वो उस टाइम पे सीटी स्कैन करने वहां से बॉम्बे चला गया था.
Just for the
सुपर वहां आके दिखाने के लिए पीछे आ गया, क्योंकि endocrinology had a monopoly there. And बेड पे बिठा के. So the point is, अब 80s में तो we cannot say life was primitive. Iridomenacea was very well established. At least PJ में तो we used to do it at Librum. So things are still, when I look back ना, मुझे कभी वो हंसी आती है कि हमने डीएम किस पे किया. पीसीओडी की डेफिनेशन नहीं थी. हमने पहली बार लड़ाई की कि डायबिटीज की डेफिनेशन पे ऑडिटोरियम में डॉक्टर दिस क्या सरदार जी का नाम क्या था जो उसमें था, वो So, Jasbir Singh Bajaj.
Right.
So he was the vice chairman of the WHO committee. So
Right. Right.
many things we have walked quite a miles, but I personally
Hmm.
think quite few milestones are still to be awaiting.
Very true. Very true. So it's lifelong learning, sir. I think that I'm sure most endocrinologists would have learned that अभी जो उन्होंने उनके DM days में सीखा है, it is just a tip of an iceberg. There is a lot more to learn over the years, and I think so we have a couple of exciting audience questions also, sir. Will come up soon. एक और चीज है sir, just to kind of build on this fact. Hypothalamus. So you have the ventromedial and the ventrolateral aspects of hypothalamus. We see patients with craniopharyngioma or जिनको those have undergone pituitary जिनकी surgery हुई है, suprasellar surgery हुई है, कभी-कभी these areas get damaged because of this, and they have differences in terms of satiety center. एक सर मेरा patient था जिनका the satiety center in the hypothalamus was damaged because of surgery. And his wife used to say कि ये तो कुंभकर्ण जैसा है, right? ये पूरे दिन खाता रहता है. He had absolutely no satiety. So you have the ventrolateral hypothalamus, which is which increases the appetite, and ventromedium, which leads to satiety. So I think that is what this patient had, and he would keep eating all the time, and that. And now we know also, sir, के जो हमारे ये जो GLP and hormones हैं, they also act at the central nervous system level as well, or they lead to reduction of satiety at this level also. So few things, sir,
Om, यहाँ पे
which lot of जी सर,
I
please.
would like, you raised a very fascinating point. अभी आप जब जैसे आपने किसी पेशेंट का वहां पे लेजन देखा या सर्जरी की, या जैसे क्रेनियोफारिंजियोमा की आपने बात की, कभी वो रिकरेंट सर्जरी करनी पड़ती है, रेडियो एक्टिव ट्रीटमेंट देना पड़ता है, रेडियोथेरेपी देनी पड़ती है. नाउ ये एक टैंजिबल और स्ट्रेट फॉरवर्ड मामले हैं, राइट? नाउ इफ यू लुक बैक, जो हम आज की जो अहम बात है, ओबेसिटी, भाई आप कम क्या करो, मोटे होते जा रहे हो. आई एम लाइक, आई फील ashamed. I said it for 2 decades. मैं किसी और को नहीं, यार कोई यहाँ का मानते नहीं या कुछ, दिन ब दिन यहाँ से 90 किलो गए थे, 95 किलो आ गए.
Right.
You in your own young dynamic experience, you must have also seen it in the last 5-7 years you have been around, right? यार कुछ सुनते नहीं, और वो कसम कुरान वहां से करता नहीं, इतना सर नहीं खाते हैं, पता नहीं क्या होता है, चल वो भी करता, ये भी. This is what prompted people says that it is not that people deliberately do it.
Right.
There are things that happen to us.
Correct.
It's something like, you have a kid with a VSD, और आप उसको रनर बनाना चाहते हो without repairing it.
Right.
अब उसकी गलती नहीं है कि वो कर नहीं पा रहा है, गलती आपकी है कि आप वो डायग्नोज नहीं कर पा रहे हो, डायग्नोज करके आप उसको रिपेयर नहीं कर पा रहे हो. ठीक से. So in a similar fashion, now it is understood. अभी आपने ब्यूटीफुली पहले प्रिल्यूड में ही कहा कि WHO ने भी अभी रिसेंटली, आई थिंक फर्स्ट वीक ऑफ दिसंबर ओनली, उनके गाइडलाइंस आई अबाउट ओबेसिटी. नाउ पीपल रियलाइज, यस, खाना पीना कम तो ठीक है, एक्सरसाइज तो ठीक है हर आदमी के लिए. No, that we keep on yelling for the last 4 decades. But there are certain people which, in spite of this, are not able to contain their weight, and it's a tangible group.
Yes.
So it is in itself a pathological process. Whatever are the basic underlying pathophysiological factors, we are now trying to understand. जैसे अभी आप हार्मोन के कह रहे थे, GLP-1, GIP की बात कर रहे थे. अब किसी को इसकी, as you said, suppose somebody has a leptin resistance,
right.
अब उसमें उसकी खता क्या है?
Correct. From the childhood, the patient is super obese, right? So
super obese, leptin hai, you can't, if you measure it, it's sky high, but there's no receptor to act on,
work on it. Correct.
And now हमने ये मोटी चीज, अब ये हमारे जहन में आ गया कि लेप्टिन रेजिस्टेंट हो सकता है. बट इन अ सिमिलर फैशन, जो मैं वो 4-5 हार्मोन्स की बात कर रहा था ना, मैं इसलिए उन 4-5 हार्मोन्स की बात कर रहा था कि हमने ये देखा, सुना, पढ़ा, इसके तोड़ जोड़ देखा. But I'm sure there'll be still small nitty-gritties that need to be understood. And Just because you don't understand it, we cannot attribute it to patient's behavior
Very,
alone. This has
very true.
been, that's why, now we know it is a definitive disorder and it needs to be
Yes,
treated like that. And जैसे आप
yes, yes.
ब्लड प्रेशर का ट्रीटमेंट करोगे, जैसे आप डिसलिपिडेमिया का ट्रीटमेंट करोगे, जैसे
Hmm,
आप
hmm.
डायबिटीज का ट्रीटमेंट करोगे,
Right.
अब इसका भी ट्रीटमेंट करना है. And that's where the
Hmm.
catch lies. That renewed thought process, it wasn't there.
Right,
It was sarcastic.
right,
It was
right,
judgmental.
right. Yes.
That sarcasm and judgment should go now. And
Very true, sir. So
empathy
this is
should
very
set in.
interesting point. Yeah, very
The
interesting.
empathy
Sir,
should set
I
in.
mean, yes. No, very true, sir. है ना कुछ मैं I'll just say बहुत सारे time you have that I still remember, that's why I told you that endocrine gurukul, now I remember the name also. I still remember listening to you, so fascinated by you. कुछ चीजें होती है ना, कभी कभी you have that idea in your brain, you have that bulb tickling that this is a great concepts that you put. Just like we don't say that we don't blame the patient for having organic disease, like उसको अगर stomach का cancer है तो हम उसको थोड़ी blame करेंगे, तू तेरे stomach का cancer हो गया, क्यों तूने ये किया, right? Same way, and I think very true that obesity is a disease in itself, right? There are a lot of times where it is not the patient's free will कि वो ज्यादा खा रहा है, कम move कर रहा है, exercise नहीं कर रहा है. There could be potential organic defects which it is probably at a level our failure also that we are not recognizing it, but at the same time, now that we have medications available, we could offer them in terms of treatment. सर एक दो इंटरेस्टिंग चीज है जो ऑडियंस ने पूछी है, और आई थिंक ये एक ऐसी चीज है जो जो अगेन a teacher like you would be helping us understand also. Somebody has asked about, an audience member has asked about the role of TNF alpha and interleukin 6, the chronic role of chronic inflammation in all those problems, sir. तो हमने एपेटाइट के बारे में बात की, हमने सटाइटी के बारे में बात की, हमने गट हार्मोन्स एंड सेंट्रल नर्वस सिस्टम के बारे में बात की, सर. थोड़ा little bit about understanding about the role of chronic inflammation in all this process, the role of TNF alpha and role of IL-6 in this.
This is what I was I told you there are lacunae in that, in our understanding still.
Correct.
Now
Correct.
let us look at the other way around.
Yes.
We now know today we now know that adipose tissue is a full-fledged organ in the body, and it's a
Yes.
dynamic endocrine and immune system.
Yes.
Right?
Yes.
And
Yes.
if you look at the endocrinology of this, and if you look at just let's say talking about a simple like highly sensitive C-reactive protein to
Yes.
let's say TNF alpha of anything, this is indicative of a sickness of an adipocyte, which we call it adiposopathy. A fat cell is supposed to, there's a particular number of fat cells a person is, a healthy person is supposed to have. You have more of them, you have a problem. You have a less of them, it's needed for survival, for those, lean periods in life. And now, if there is whatever triggers that inflammation, whatever triggers, many of those pathways are not, we already know that they can cause endothelial dysfunction.
Yes.
They can cause beta cell dysfunction. Even free fatty acids are toxic to beta cells, right? Or not?
Correct.
I mean,
Absolutely,
they can aggravate beta cell apoptosis. That's why we don't talk about only glucotoxicity. We talk about lipotoxicity, right?
Correct.
And in that same lipotoxicity, I think we talk about the same immunoinflammatory stuff also making our vascular endothelium sick. Now you are talking today about cardio, metabolic thing, and it gets connected. And I'm sure that it connects at multiple places. And because अभी तक तो हमने वो pituitary, thyroid, adrenal gland, gonad ही देखा था. Now we are diversified.
Correct.
You see,
correct.
I was one day, vitamin D metabolism we have been talking about for a long time, right? और लिवर में ऐसा होता है, किडनी में ऐसा होता है, ये पढ़ा आपने? हमने भी पिछले 40 साल में पढ़ा है और पढ़ा.
Right.
I was in a meeting. DeLuca is the guy who discovered 1-alpha hydroxylase.
Right. Right.
And we had described one alpha hydroxylase from here. It was the only case report from Asia in literature.
Okay.
And Deluca's one student, and that student was 2 decades back, 85 years.
Right.
We were together in a meeting, and it was a meeting on vitamin D. What is normality? Indo-US
Mm-hmm.
meeting. It was a Canadian
Right.
basically, and
Right.
then suddenly we found out the same vitamin D, activated vitamin D that was coming from renal parenchyma, also comes from lung tissue, also comes from
Yeah.
colon. But it's a very
Correct.
minuscule amount that acts locally. So people started talking about,
Right.
does it have a role in malignancy? Does it have a role in multiple sclerosis? Does it? So in a similar
Right.
fashion, the last word on obesity is not yet understood.
Right.
And every time we understand a facet, we
Hmm.
try to combat it with strategies that we can develop. I'll
Right.
give us some.
Right.
अब किसी का फीवर होता था पहले,
Hmm.
you give an antibiotic. Now
Hmm.
you diagnose it typhoid fever. You
Hmm.
know what to give him. You diagnose it tuberculosis. But then
Hmm.
you have a fever of unknown origin.
Right.
You're struggling to understand it. You're keeping the person
Hmm.
alive. So in a similar
Hmm.
fashion, again, when you look at this whole gamut of obesity,
Hmm.
one size will not fit all.
Once. Yes.
अभी हम
Absolutely.
आज के वक्त की बात करें, आप और हम,
Hmm.
आप तो आज के जमाने के
Hmm.
ब्रिलियंट डॉक्टर हो.
Thank you.
अब we are also now given these medicines for quite some time. I
Hmm.
would not name the products, but वो
Hmm.
GLP-1 receptor, SGL2 inhibitor से ही. See the difference between two people. जब वो सीटाग्लिप्टिन का जमाना आ गया ना, 30-40 रुपए की टैबलेट थी, तो
Hmm.
एक somebody was advised insulin क्योंकि सल्फोनाइलयूरियाज ही तब तक थे, and you give me
Right.
gliptin. डॉक्टर साहब, he would say, डॉक्टर साहब आपने तो मैजिक कर दिया सर. थैंक यू सर, थैंक. मैंने कुछ नहीं किया था. हमने क्या किया?
Right.
वो
Right.
जस्ट,
Right.
हम तो उससे पहले इंसुलिन उसको बताते, वो एनपिच वाला इंसुलिन,
Hmm.
हमारे पास और कुछ था ही नहीं. नो द
Right.
सेम ड्रग टू सेकंड पेन. डॉक्टर साहब ये 50 रुपए की गोली खाई, कुछ नहीं हुआ.
Hmm.
There was, biological underlying pathophysiological variability. So एक एक अब
Right.
क्लियर हो गए ना, हमें SGLT कहाँ पे
We
देना
are
है,
understanding it.
बायोग्लोबुलिन
Correct.
लगेगा,
Correct.
प्लेटफॉर्म कहाँ कंटिन्यू करेंगे, कंबाइन कहाँ पे
Right.
करेंगे. इसी तरह से
Right.
now you give let us say GIP-1 or GLP-1
Hmm.
combined.
Hmm.
एक बंदा आता है, so suddenly I have so many people. One day one youngster flew from Bangalore to see me
Hmm. Hmm.
because he was conceived after the treatment I had given to his mother. उसके माँ का
Right.
प्रोलेक्टिनोमा था, और उस जमाने में
Right.
प्रोलेक्टिनोमा डायग्नोज
Right.
करना 137 kilos. His father asked him to come here, और
Right.
2 महीने में उसका 18 किलो कम हो गया, और तीसरे
Hmm.
महीने में कहता अब और क्यों नहीं कम हो रहा है, 18 किलो हो
Ah.
रहा है. So magic happening. And then there are other
Right.
डॉक्टर साहब, वो तो हम अब 2 महीने से ले रहे हैं, 1-1.5 किलो कम हो गया. सो इट मीन जो
Hmm.
भी अंडरलाइन बायोलॉजी है ना, उसमें कुछ डिफरेंस है.
That's different.
जब
Correct.
हम
Correct.
कहते हैं ना वो हाईली सेंसिटिव टू द ड्रग,
Hmm.
आप अभी ले गए,
Hmm.
आप जो आजकल 2-3 पॉपुलर ड्रग्स हैं ना, अब
Hmm.
एवरीवेयर विल से, यू विल सी इन about 50-70% people magic happening. It is something like
Hmm.
treating old times typhoid fever. 3 दिन में टाइफाइड खत्म.
Correct. Correct.
ओ क्या बढ़िया
Patient
डॉक्टर
का
है.
weight एकदम. Yes.
हाँ.
Absolutely.
अब जब वो बीच में बचते हैं ना, वो 10-20%,
Right.
they will have varied etiologies. उनके लिए different way.
Yes.
उनके लिए वो
Correct.
ग्लूकागॉन एगोनिस्ट, उनके लिए ये इम्यून.
Right.
There was a
True.
study on coronary artery disease giving a monoclonal antibody to combat these interleukins,
Correct.
and it found
Correct.
an amazing
Even.
thing like statins. So
Correct.
I'm sure that the same thing is en route down
Will.
the line for
Very true.
obesity and adipocyte mechanization as well.
Right, sir. Colchicine was already also tried for atherosclerosis. There was paper published in NEJM as well. So I think it's a very interesting point. Again, for the audience, let me reiterate what sir said. Very beautiful thing. पुराने ज़माने में, I say, Alexander Fleming, for example, first came up with the antibacterial. तब any fever you would give the same antibiotic, right? But now up to without culture, it will be a crime to really give an antibiotic. अभी ये ज़माना आ गया. So I think we are moving more from. Right now, we are in the first generation of obesity treatment where we are giving one drug that fits all. But in future, I think we'll understand these mechanisms better, and we'll go to a more precise precision medicine in obesity also, as we are already doing it precision medicine in diabetes. We published a paper recently where we talked about a mathematical model where we could have precise drug and anti-diabetic drug for precise patients. Same way, I think in future, maybe 10 years down the line, we'll be talking about anti-obesity precision medicine, where we'll be giving the right drug for the right patient. I think, and somewhere sir, ये हम भी बात करेंगे, एक जमाना था जब हमारे पास दो दवाई होती थी, right? दो injections होते थे, right? Either it patient would lose 18 kg or patient would lose not even 1 kg, right? So
Absolutely.
very interesting, very very true. सर वन मोर थिंग, एक और चीज है जो जो बहुत आजकल बहुत टॉक में है, लॉट ऑफ पीपल इसके बारे में बात करते हैं, फैटी लीवर. सो हाउ डज फैटी लीवर, बिकॉज जैसे जब जब भी हम ओबेसिटी की बात करते हैं तो फैटी लीवर की भी बहुत डिस्कशन होता है, right? So what really, how does obesity and adiposity connect with fatty liver, sir? Because that's a question also somebody has asked from the audience also. It's a very interesting area. Little bit about that, sir.
When these ultrasounds started becoming popular,
Yes.
late 80s, and people used to come, our institute was one of the first to have these high-tech imaging and all that.
Right.
तो मैं अक्सर कहता था ये तो फैट हर जगह है, अब लिवर में कहाँ, यहाँ पर भी आएगा, तो बाजू में पेट में इतना है, पेट निकला हुआ है.
Right.
But now today, it's amazing that another remarkable change in our lifetime. The commonest cause of liver dysfunction, liver failure, liver mortality, most part of our life was different forms of hepatitis. In fact, my postgraduate thesis was post-transfusion hepatitis. And today, if you look at the commonest cause of liver transplants, it's for fatty liver disease. And अभी हम पिछले 2 साल से, we published a detailed, in-depth paper on summarizing the whole data on metabolic liver disease this May only. Many times when you look at the fat accumulation in the body, एक तो normal fat tissue, as everybody has a fat tissue, जैसे muscle है, bone है, fat tissue है. Now there are certain pathological processes. When you have excess fat in the body, that excess fat gets accumulated in aberrant places. Like, you get a pericardial fat, you get an epicardial fat, you get a peripancreatic fat, you get a perinephric fat. So in a similar fashion, you get a fat in the liver. This is an ectopic fat, right?
Correct.
Now, whenever there is a spillover of fat in the body, it gets deposited in many areas. But you also will find out in some pathological situations, the person may not be morbidly obese by the conventional criteria.
Right.
But still there will be this ectopic fat. And this ectopic fat is what will designate the potential chances of dysfunction of that organ.
Yes.
Right?
And that is what we understand more now, sir. Okay, बहुत सारे organ dysfunction, including you talked about epicardial fat, which is now postulated as an important cause of heart failure with preserved ejection fraction, HFpEF. Again, one disease where nobody used to talk about this disease 5 years back. Now we all talk about HFpEF. Same way, now you talked about perinephric fat. There is intrasinusoidal fat also in the kidney, which has also been attributed to potentially causing renal sinus fat, which has been potentially causing renal dysfunction. So I think very interesting. Again, as for the audience, like sir said, the adipocytes can't hold fat anymore. It spills over as free fatty acid. Free fatty acid is toxic. A lot of it gets taken up by the liver, and then you have the ectopic fat deposition in the liver. And that fat on a long term can have chronic inflammation and lead to what is known as MASH, and what then develops into cirrhosis of liver over a period of time. So I think that's the mechanism. So I think we had very fascinating discussion. I think we are almost close to
anything,
yes, sir, please.
anything that helps us to reduce this ectopic fat. जैसे मैं तो भारत का कहूंगा, अपने मुल्क का कहूंगा. जैसे हम कहते हैं ना, हम उतने मोटे वजन के हिसाब से नहीं, मगर हमारा पेट बाहर निकला हुआ है. मैं तो 30 साल से सेंट्रल, मैं तो कहता है शेल्फ जैसा हमारा पेट है, बाजू सूखे पड़े हैं.
राइट।
माई बिलीफ इज, अब जैसे ना, जैसे आप बेनिफिट देख रहे हैं, जैसे एजएल2
हम्म
इनहिबिटर्स का,
हम्म।
coronary, renal, blah blah blah, hepatic, और
करेक्ट।
SGL2, just GLP-1 receptor agonist का, dual agonist का, triple agonist का, anything that gets your abdominal fat down. My
राइट।
belief is that it takes away that ectopic fat from different sides,
करेक्ट।
right? And that's why
करेक्ट।
your liver does not get choked, the hepatic failure
हम्म।
less chances. Your
राइट।
heart does not get choked, less chances of
हम्म।
failure. Your vessels
करेक्ट।
don't get choked, you get some relief from a coronary artery disease for a few
यस।
additional years. Your kidneys
यस।
don't get choked, the nephrons don't get choked, some more relief for a few years on. So the point is strategically placing them in time
राइट।
so that the benefits are
राइट।
longer lasting before the
वेरी ट्रू।
terminal damage is done.
वेरी ट्रू। वेरी ट्रू।
Ultimately, I would say probably still. You see, we are thinking loud this time, Om, and time will tell us which directions things will take. अभी मैं
यस।
सिंपल बताऊंगा कि जब वो SGLT2 आ गए, आई वॉज वेरी केयर, मैंने कहा हम लिखने वाले नहीं है, हमारे यहाँ तो सिर्फ इन्फेक्शन से ज्यादा लोग मरते हैं, अब क्या मैं पाइलोनेफ्राइटिस से मारना है क्या? सो इट टुक अ
राइट।
व्हाइल टू
राइट।
अंडरस्टैंड कि आप डायबिटीज कंट्रोल
यस।
कर लो, इंसुलिन भी नहीं हो जाएगा.
राइट। राइट।
So I'm sure that these many facets will get connected. हर साल इसमें से एक एक जुड़ जाएगा.
इट्स लाइक अ
And
पजल व्हिच इज।
the coming
यस।
generations would be better empowered to make more precise decisions. As you made a beautiful mention of, we're talking about already of precision medicine. And I'm sure
राइट सर।
that precision medicine would start from controlling obesity, and that will be taken care of not only diabetes, coronary artery disease, fatty liver, and potential renal dysfunction.
वेरी ट्रू। Very true.
Over to Om.
So I think yes, thank you, sir. I think that's a very fascinating thought to end today. We are close to an hour to that, sir. I mean, absolutely, sir. मैं इतना कहूँगा, sir. It was a fascinating discussion. Absolute pleasure. And बहुत सारी चीजें, sir, है ना, आपने जो कही, right? Like I said, you have that little eureka moment in your head, right? तो मैं ये session के बाद I'll write it down somewhere. I made the system like second brain जैसा, जिसमें ना जैसे interesting चीजें जो है वो put it up in that system. I think a lot of these things are going to go into that. Beautiful learning, sir. I think it was absolute pleasure connecting with you, sir. And
Same here, honestly. I enjoyed this 1 hour.
Me too, sir. Absolutely, sir. बहुत मजा आया. And I think I always had like I said, right from the time I first saw you in the endocrine gurukul, we have met many times over the years, sir. But I think always your fan, always fascinated by you. And sir, you are you're a great teacher, a delightful person, and you have those ideas in your brain, sir. Fantastic, sir. Thank you so much. I think I'm sure the audience would also have enjoyed a lot today. Dear audience, thank you all for being part of this Dr. KK's Med Talk. We from behalf of KK's Med Talk team, I would really like to thank Dr. Abdul Hamid Sargar, sir, or Dr. Hamid, as you would like to be called. I think ये भी मुझे याद रहेगा, sir. अब ये मैं नहीं भूलने वाला. This is a take home message for me also. So thank you,
God
sir,
bless you.
and thank you for joining us today. We'll end the session today, and we'll hope to connect very soon, very early. Sir, एक last question है. एक before आपको, sir, audience is really looking forward to this question, sir. एक last question आपके लिए, sir. We talked a lot about precision medicine and other things. थोड़ा सर एक लास्ट टॉक ऑन जेनेटिक एस्पेक्ट्स ऑफ फैटी लिवर, बिकॉज कुछ लोग ना लोग देखते हैं कि फैट बहुत सारे लोगों में होता है, लेकिन उनमें कुछ लोगों को ही डिजीज होता है, सिरोसिस होता है, बाकी लोगों को नहीं होता है. सो इज देयर सम जेनेटिक्स टेकिंग a player there, or is there something there?
I have a friend
Yes.
who was 1 year junior in the medical college and retired as dean of our own institution.
Right.
I was always telling him from the medical, मैंने कहा यार खुर्शी तू इतना खाता है, कभी मोटा नहीं होता. हम विंटर वेकेशन में 4 हफ्ते चले 2 किलो बढ़ के आते हैं, फिर
Right.
6 महीने वो 2 किलो नीचे लाने पड़ते हैं. तो विंटर वेकेशन का
Right.
मजा ही
Right.
किटकिटा हो जाता है. यस,
Right.
देयर इज अ जेनेटिक कंपोनेंट. अभी जैसे आप सिंपल लो, वी जस्ट नॉट डिस्कसिंग लाइक we're talking about, let's say, leptin resistance. We raise something. So genetic control of the receptor. I remember one of the
Right.
first things, Lancet mein, there were two siblings from Pakistan in England, leptin resistance and how it can be broken and what can be done about it. So yes,
Right. Right.
जो भी pathways है ना, pathways जो है ना, उनमें genetic control है. Now पहली बात जो
Hmm.
आज हमने की, we talked with GLP-1, right? और
Correct. We started with GLP-1. Yes, sir.
जब सीटाग्लिप दिस इम्पोर्टेंट जिसने भी पूछा उसके लिए सीटाग्लिप्टन जो कार्डियोवास्कुलर आउटकम ट्रायल था टीकॉस था राइट
Right.
एंड
Correct.
एमएसडी ग्लोबल जो उनका
Hmm.
यूएस वाला है ना दे
Hmm. Hmm.
ऑर्गेनाइज्ड
Hmm.
अ मीटिंग इन बार्सिलोना विद रिसर्चर्स की आप हमारे डेटा में देखो कोई because it was a university driven trial not by industry driven trial
Right.
money was
Right.
given to the
Right.
university no
Correct.
Cambridge conducted the trial, and
Hmm.
said they
Hmm. Hmm.
called us and said they'd got about 100 odd endocrinologists and cardiologists from different parts of the country.
Hmm.
Or for
Hmm.
as luck would have it, India say do Kashmiri Lake, Upender Kaul, cardiologist I was taken there,
Right.
and they said you look at it. दो चीजें पहले थी कि कहीं पेनक्राटिक कार्सिनोमा तो नहीं है, कहीं पेनक्रेटाइटिस तो
Right.
नहीं है, हार्ट फेलियर तो नहीं है.
Hmm.
वो उन दिनों वो
Correct.
एक्साग्लिप्टिन
Heart
बड़ा
failure.
हो गया था वो.
Sexagliptin.
Yeah.
Sexagliptin ka.
And we have such a huge data. Can we do something different?
Right. Right.
Can we do something different? अब मैं जब वो देख रहा था तो पूरा 2 दिन देखा मैंने कहा यार हमारे मुल्क में हमें लगता है मैंने कहा देखो आप लोग 5-10 पेशेंट देखते हो हम तो 100-150 देखते हैं अब इंस्टीट्यूट में
Correct.
हमारे दिन एक ओपीडी में 400 लोग होते हैं दिन को तो मैंने कहा
Hmm.
हमें लगता है कि हमारे लोगों में इट वर्क इज बेटर
Right. Very
then
true.
they said we'll look at it then they look जो
Yes.
टीकास का डेटा था ना they isolate the Asian
Hmm.
data जो उनका
Hmm.
0.8 0.9 HbA1c था it was 1.2 to
Hmm.
1.4 in
Right.
and there was a
Very true.
paper published by a friend of mine from Center for Cellular Biology from Hyderabad
Hmm.
that we have a genomic tendency for this GLP-1 deficiency and a big chunk of our people have this deficiency there. So genetic control nikla na. So it's matter of looking at it and being good enough to identify it.
Very true.
So if you look at leptin resistance and if you look at this our own genetic tendency to have a more GLP-1 deficiency in a bigger chunk
Hmm.
of patients with type 2 diabetes. So the more we understand, last one word.
Yes.
When we talk about a billion guys having obesity,
Hmm.
when we talk about 10 to 20 crore people in our country having diabetes,
Hmm.
when we talk about somebody briskly responding to drug A, the other
Right.
one not changing a bit, right?
Hmm.
It means underlying pathophysiologically they are different. And many of those
True.
differences are genetically determined.
Very true. Very true.
Yeah. And
Absolutely, sir.
they just need to be unearthed.
Correct. And we need to understand that and research more, maybe. Very true, sir. And I completely agree with your insight on the DPP-4 inhibitors, and it's really very effective in Asian patients, as you've seen over the years. I think I'm sure GLP also hopefully would be very effective. So I think, sir, we had a lot of appreciation from the audience who listened to this. We have people saying a very informative talk, and thank you for being part of this, sir. I'll end by saying that we are all grateful to you, sir, for this wonderful insight. I think a lot of new
Pleasure.
ideas, a lot of new
Pleasure.
insights. Thank you so much, sir. And
God bless.
dear audience, that will be all for today. Dr. KK's Med Talks will return tomorrow at 7 p.m. with another edition of the show. And keep watching KK's Med Talks, Dr. KK's Med Talks for this such insightful discussions and such wonderful audience and such wonderful guests like we have Dr. Hamid sir today. Namaskar to all of you and good night, everyone. And thank you, Hamid
Good
sir,
night.
once again for
Pleasure,
being part of this.
Ram.
Good night, sir.
God bless you.
Good night, sir.
And
Thank
gratitude
you.
to the